gonadotropin and fertility treatment. And this is the product of Aris Pharma. And what is human chorionic gonadotropin? HCG is produced by the placenta, specifically by syncytial trophoblast cells of the developing embryo, placenta after implantation, and human HCG is commercially obtained from the urine of pregnant women. Naturally, it is extracted from syncytial trophoblast and artificially from the urine of pregnant women. It stimulates steroidogenesis in the gonads. Its biological effect is similar to luteinizing hormone. HCG approved uses. In female, HCG is approved in female for sterility due to absence of follicle ripening or ovulation. It is also used in combination with FSH or HMG for controlled superovulation in medically assisted reproductive program. HCG is also used for luteal phase support, recurrent abortion, and threatened abortion. In males, HCG is approved for HCG hypogonadotropic hypogonadism, delayed puberty associated with insufficient gonadotropic pituitary function, sterility in selected cases of deficient spermatogenesis. Role of HCG in ovulation trigger. During the late follicle phase, high estrogen level stimulate the LH surge. In IVF cycle, the natural LH surge is suppressed using GnRH agonist or antagonist. Therefore, an external trigger is required to induce ovulation. HCG is commonly used as the external trigger. Due to its prolonged half-life, HCG also supports progesterone secretion from the corpus luteum. In IUI cycles, HCG triggers help achieve more predictable timing of ovulation and insemination. Role of HCG in luteal phase support. GnRH agonist or antagonist use can suppress LH, leading to iatrogenic luteal phase insufficiency. High estrogen level during the anticycle may further suppress LH flow negative feedback. Reduced LH support can impair corpus luteum function after oocyte retrieval. Without luteal support, estrogen and progesterone level falls, making pregnancy difficult to sustain. Poor luteal hormone support may also affect endometrial receptivity. Hormone supplementation with HCG or progesterone is commonly used for luteal phase support in IVF cycle. Role of HCG in male hypogonadotropic hypogonadism. HCG acts as the LH substitute in hypogonadotropic hypogonadism. HCG is usually given before FSH to stimulate Leydig cell function. HCG stimulates Leydig cell to secrete testosterone. Intratesticular testosterone may rise up to 100 times higher than peripheral circulation. High intratesticular testosterone is essential for induction of spermatogenesis. In some patients, spermatogenesis may be achieved with HCG alone, which is not possible with FSH alone. Role of HCG in prepubertal cryptorchidism. HCG may use in prepubertal cryptorchidism when there is no anatomical obstruction. HCG is thought to induce testicular descent in cases where descent would normally occur at puberty. Response to HCG may help assess the likelihood of spontaneous or hormonally induced descent. HCG therapy may help predict whether orchipexy will be required in the future. So these are the doses of HCG. In ovulation reduction, 5,000 to 10,000 given after the last gonadotropin dose. In aortic or controlled ovular stimulation, 5,000 to 10,000, 30 to 40 hours before oocyte retrieval. In luteal phase support, 1,000 to 3,000 IU, 2 to 3 repeat injection within 9 days, day 3, day 6 and day 9. And male hypogonadism, 1,000 to 2,000 IU, 2 to 3 times weekly. How it is better than LH and GnRH agonists. Recombinant LH may be associated with lower implantation rate. It may be associated with higher OHSS rate reported to 12%. It can significantly increase the cost of treatment. And GnRH agonist trigger can be used only in GnRH antagonist ovarian stimulation protocol. It may cause an abnormal luteal phase. Lower success rates have been linked to low early luteal LH level. Empty follicular syndrome has been reported in 1 0.4 to 3.5% after GnRH agonist trigger. No consensus for GnRH trigger dose. Now, advantage of HCG for ovulation trigger. Used for decades for final follicular maturation. HCG is used as a trigger because it is structurally and functionally similar to LHF through the same LH-HCG receptor. Can be administered by either IM or subcutaneous route. Can be used in both GnRH agonist and antagonist cycle. HCG has a longer half-life than endogenous LH. A bolus dose of HCG can support corpus luteum function for 7 to 10 days. HCG has extensive clinical experience as it has been used for decades. When GnRH agonist trigger fails, HCG can be used as a rescue trigger to achieve oocyte maturation. HCG is associated with a lower incidence of ectopic pregnancy compared to GnRH agonist.